Top Med Talk. Well, hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm here with my co-host, Joff, Lacey, and it's great to be back at EBPOM, Evidence Based Perioperative Medicine, at the World Congress in London. Really nice to be back, isn't it, Joff?
Very nice, yeah. I've had a few years hiatus living and working in Australia, so this is my first time back. It's great to be here. Thank you.
Back on the headsets, back on the mics, straight in.
Exactly. No, and as always, there's a great buzz about the meeting, so fabulous to be back.
Well, we've just had a really, really inspiring session on experimental medicine, which is probably quite a new topic for us here at EBPOM, but it's great we've got two of the brilliant speakers who've agreed to come and chat to us more about what they presented, and I'll let them introduce themselves for us.
Thank you very much for having me. My name is Malcolm West. I'm an associate professor in colorectal surgery and Prehabilitation Medicine at the University of Southampton, and I'm also a complex cancer and colorectal surgical specialist consultant surgeon at the University of Southampton Hospital Trust. Brilliant, thank you.
Hi, I'm not as regular as you are, Malcolm, but my name's Colleen Dean. I'm a lecturer in muscle cell biology, also from the University of Southampton.
Brilliant. And so Colleen and Malcolm, you've just given really, really interesting, inspiring talks in this session, which was called Experimental Medicine. I mean, for our listeners at home, what is experimental medicine?
So I think experimental medicine is the translation between bench to bedside, looking at innovative outcomes from lab medicine and translating them rapidly into a patient population. That's what I mean by experimental medicine.
I think it's notable that in the session we just had, so there's yourself as a surgeon, Colleen is a very experienced laboratory scientist, and John Whittle, who's another well-known name to Top Med Talk as a perioperative physician anaesthetist. So actually this experimental medicine concept is very multidisciplinary, isn't it? It spans the whole spectrum. I guess there's lots of things we could talk about, but you've both covered a number of topics in the talks. I guess the common themes for me listening in were 1, exercise, and 2, muscle, and then underneath that maybe the mitochondria. So I was thinking we might start talking about those 3 things to start with, but we can see where it goes after that. But do you want to start with the exercise work, Malcolm? Telling us what you were...
So we've been doing in Southampton and nationally, we've been doing something called Prehabilitation. Prehabilitation is essentially multimodal interventions, exercise being one of them, nutrition and psychological interventions to improve outcomes after major surgery. And that could be for cancer or not for cancer. Our journey started more than 10 years ago now with looking at risk stratification in the perioperative environment. My pet subjects are colorectal cancer surgery. We found all those years ago that these patients do have quite a lot of morbidity after major surgery, and we wanted to do something about it. And we also found out that patients lose quite a lot of physical fitness and resilience during cancer treatments. So for especially locally advanced rectal cancer, locally advanced esophageal cancers, all reduce the resilience and physical fitness and decrease the activity and quality of life. We then established a Delphi consortium to essentially undertake an interval exercise training pathway, which is called Prehabilitation. And so we've started off with 6 weeks, 3 times a week, 40 minutes of high interval intensity training, or HIIT. HIIT has been developed since then. We did a 3-week versus a 6-week. We did a 6-week, we did a 9-week intensity training program in a variety of cancer cohorts. So simple colorectal cancers versus more locally advanced esophageal, urology, and also rectal. And now we're in the palliative space, so palliative lung cancer and also palliative hematogenous cancers. And we've found that you can improve physical fitness and resilience. You can rescue that decline in physical fitness with chemotherapy or radiotherapy. And you can also offer a concomitant increase in quality of life. The most exciting thing as a surgeon, I think, that we do find a 50% reduction in major complication rate as per the big prehab trials that have been published recently. From an experimental medicine point of view, in my lab, we look at mitochondrial biology. My PhD was mitochondrial energetics, and we do find in patients who have a substantial hit with chemoradiotherapy that their mitochondrial function is declined, and that can be rescued by HIIT training. And that could improve lots of other post-operative outcomes.
Can I ask on that, with your HIIT training, at what stage in their treatment pathway do you instigate that? Great
question. So you could do it at any stage preoperatively. So in the locally advanced esophageal cohort, we've done it during neoadjuvant chemotherapy and radiotherapy, and that is feasible, tolerable, safe, effective. So you don't get the dip with the classical diagrams for the prehab where everyone kind of declines and then you have to rescue it. the exercise arm just stay the same or even increase in resilience during their chemotherapy. And then they have a dramatic uplift if that continues after chemorad. In the rectal space, we have not done it during radiotherapy yet, but that's the plan. But we've always done it immediately after chemoradiotherapy. And then that's, again, tolerable, safe, effective.
And the drop in physiological form, is that seemingly due to the neoadjuvant treatments or just by cancer per se?
I think it's a mixture of both. So my cancer patients, the ones we study, have really bad physical activity. We give them accelerometers or even use their watches. Their baseline function is really poor, less than 5,000 steps a day. That declines to about 3,000 when they're having the adjuvant treatment, and that goes back to roughly 5,000. Everyone gets a cardiopulmonary exercise test, so it's an objective measure of physical fitness. And again, their physical fitness is borderline at best to begin with. They then get hit with a cancer treatment of any kind that reduces roughly by about 1.5 to 2 mils per kilo in their anaerobic threshold and about 3 mils per kilo in their peak. And then that could be rescued and they overshoot their baseline with a 3-week intense HIIT training program.
Wow.
And you mentioned, Malcolm, about the mitochondrial aspects of that, which is a good point to bring Colleen in. So Colleen, you're probably one of the world experts on mitochondrial translational physiology, but remind us what the mitochondria does, how it works, and in very brief terms, people that may not be quite as current on the mitochondrial work from medical school as you are.
Yeah, sure. So, I mean, I'll just preface this, I should have said it in the introduction, but I'm basic scientist by training. So my experience in the kind of clinical and perioperative world is relatively new, but the mitochondria, so they're an organelle that we have within our muscles. They're very abundant. That's the tissue that I'm very much interested in. And their fundamental role that most people are familiar with is that they produce ATP. So that's adenosine triphosphate, and that's really critical for increasing or allowing the muscles to perform functional movements. But we also use that ATP in other consuming processes such as muscle protein synthesis. So that's effectively what the mitochondria do. And we've done some of the work that I was showing today, led by the University of Nottingham, which I just had the pleasure of being a small part of. But they had run a study at preoperative study or prehabilitation in males who were told that they need to have prostate surgery. So then they had this 31-day window in which they then gave them a HIIT protocol within those 28 days. They improved their cardio-respiratory fitness, which associates very well with mitochondrial volume density. And what we wanted to do was actually see whether mitochondrial changes were associated with any of that CRF improvement that was seen in those patients. So they actually had biopsies taken before and after that HIIT intervention in those patients there. And we actually looked at the content, so the amount of electron transport chain complexes. So within the mitochondria, on the inner mitochondrial membrane, you've got what's called the electron transport chain. It allows electron flow right through from complexes 1 to 4, where it's terminally accepted by oxygen. And then the proton motive force that's generated by that electron flow then drives ATP synthesis through ATP synthase. So what we actually did was then looked at the content of those electron transport chain complexes and found that actually that HIIT intervention did increase complex 2 and complex 3 content within those patients. So we think that when you're doing or prescribing these HIIT training protocols, they're actually driving and eliciting mitochondrial adaptations, which are probably related to the improvement in cardiorespiratory fitness.
So that's making individual mitochondria more efficient or effective, is it? Or
yeah, I mean, we measured that using what's called an Oxford blot, so just a traditional Western blotting technique in the lab. So it's looking at the content of the subunits of those electron transport chains. So it's really just kind of an indirect marker, but we think that what's happened is there has been an increase in those complexes, which might facilitate better electron flow and potentially more ATP production. But really, you would also need some nice complementary measures to really solidify that, such as ATP rates or production rates.
And so, Malcolm, that may link back to the exercise whether you were talking about that there's maybe a plausible mechanism there to explain the changes we're seeing in the clinical trials.
Yeah, I think so. So again, this has started quite a few years ago, where we developed our HIIT training program and we tested it in animals and humans. The human work was doing exactly what Colleen said, a mixture of lab and also, again, experimental medicine type techniques, whereby we placed the patient inside a 3 Tesla 31p MRI scanner. And an MRI is a really convenient way to look at in vivo mitochondrial energetics. So we put a phosphorus coil on them. We did something called 31 PMRS, 31 phosphoromagnetic resonance spectroscopy. And that negates the need to take a bit of muscle out of someone, which is very patient-friendly, obviously. We then exercised those patients immediately after their chemoradiotherapy. So did a MRI before they started, did the MRI after their chemorad, and then exercised them for 6 weeks in a randomized controlled fashion. And you almost have an exact replica of what happens in those, well-publicized prehab diagrams. The mitochondrial function, both complex 2 and complex 3, decline with only a 5-week course of neoadjuvant chemoradiotherapy, and that is very well rescued in a phosphorocreatinine recovery time constant way, which is a surrogate marker to their resilience and volition. That is, the patients who have undergone the exercise training program have overshot their baseline, and their mitochondria are rescued from that deleterious effect of platinum-based compounds that we give them and the radiotherapy. We then translated that into animal work, and again in the lab you see exactly the same. The animals were given colorectal cancer. We then gave them exactly what we give to humans, which is FOLFOX chemotherapy, which is a platinum-based compound. The platinum in the chemotherapy knocks the mitochondrial function with a reduction in complex 2, and then we exercised the animals in a randomized control way, and the ones that have had a benefit from the exercise rescued their mitochondrial capacity as well.
Can I ask, Malcolm, what your hypotheses are around complex 2? Because you're clear, so if I'm understanding right, you're seeing a decline in complex 2 when there's a cancer insult. And we've seen it obviously in our study, and I think you said you've seen it where if you do an intervention, whether it be HIIT or something else, then you see complex 2 then can adapt. Why complex 2? Have you got any hypotheses around that?
No, is the honest answer. But complex 2 in the literature is one where it's easily rescuable. So that's why we interrogated that specifically. The total OXPHOS and the leakiness of the mitochondrial membrane is also impaired with a platinum-based compound. But there's no, to my knowledge, specific hypotheses around except increasing in leak and reduction in OXPHOS. The complex 3 is also, I'm not entirely sure why that has happened, but essentially you can map on the rescue of the mitochondrial element that you're looking at, and you can also map on the cardiopulmonary exercise fitness variables that you're looking at, and they complement each other, especially when you look at work rates and or total peak power output.
So a lot of, if I'm understanding this right there, Malcolm, so a lot of the, if you like, harmful interventions that we're giving to patients for good reasons, but we know they have a negative effect, seem to be impairing mitochondrial performance one way or another. And some of the interventions we're doing, which we think have a beneficial effect, are improving the mitochondrial function. So is this really just as simple as it's all about the mitochondria underneath this?
No, I don't think so. I think the human being is extremely complicated. I think that's why you kind of, again, with experimental medicine, it's a very unique way of interrogating a hypothesis, whereby you kind of go into a human trial and then back translate it into an animal trial and then find something else and forward translate it back into a bench to bedside kind of methodology. I think it's not as easy as we depict it. There are many more confounding factors. The physical fitness, baseline physical fitness of the patient, the baseline physical activity of the patient, the baseline mental resilience around the whole cancer pathway, the regaining of control, the change in behavior, and then the all-important nutrition bit, which we haven't looked at yet.
Can I just ask on the response to the HIIT training? Was there uniform improvement?
Yeah, that's a really good question. No, there wasn't.
Okay.
So there are people who are known as exercise responders and those who are known as non-exercise responders. So about 20% of the cohort are non-exercise responders to HIIT training. We chose HIIT because it's a uniquely easily deliverable way to improve someone's fitness really quickly. Remember, we're in a perioperative space, and the end goal is an operation, and that end goal has a date. So we slotted in a 6-week training program. We have seen adaptations and rescue with just 3 weeks of HIIT. But if you compare the HIIT literature versus the resistance literature or the strength literature, you don't see that adaptation.
Right.
So the non-responders to a HIIT training program are just because they're a non-responder to that training program. It is not that it means that they're a non-responder to exercise in general. You can bolt on strength, you can bolt on resistance, you can lessen or you can lessen the HIIT component, and I'm sure they will be a responder to something. We've just got lucky with the HIIT.
Are there any ways that we can change people from responders, from non-responders to responders that we know of?
Maybe that's where nutrition comes
I think the addition of nutrition. So if you improve your energy content, if you improve your calorific content, and most importantly, protein. The literature around protein, the 1.2 grams per kilo, is an all-important literature. There are lots of trials out there in the prehab space from Chelsea's group and the Franco Carli group in Montreal around bolting and nutrition intervention and an exercise intervention. And it's a mutual gain. You get benefit. So it's not a 1 + 1 = 2 equation.
I was going to say, I think it's about also optimizing the exercise, because it might be that perhaps somebody might not be responsive to HIIT, but they might be responsive. So maybe they can't improve their cardio-respiratory fitness as much as somebody could, but they might be better at maybe gaining strength if they did resistance exercise training. Yeah. So in addition to the nutrition, I think there could be optimization of exercise as well. But I think what we need to do in that space, in healthy literature as well as clinical literature, is actually identify, or how do we know who a responder might be and who a non-responder might be. So we need to identify biomarkers that might give us a bit more information about who they are in the first place. And then if there was some way to stratify that, then you could say, right, you're this type of responder, that exercise and that nutrition's best for you. You're this type of responder, that exercise, that nutrition's best for you. But I do think we're still a little bit away from that.
Colleen, do you think there is a target in some kind of mitochondrial reactions that we could target pharmacologically to either improve someone's response or make a non-responder a responder? Is there even a whiff of what that might be?
In terms of responder, I don't know. I think that we're still quite far away from even identifying, any kind of biomarkers for responders and non-responders. There is some good literature out there, but for mitochondria, I don't know. I mean, some of the data that I showed today is we've looked at a nicotinamide adenine dinucleotide precursor and NAD precursor. So NAD is a metabolite that actually donates electrons into the electron transport chain to help gain that proton motor force and drive ATP production. And we know that when you're older and you have low muscle mass, you actually have lower levels of NAD. So we thought, well, that might be an effective intervention to try and boost the mitochondria. So we've actually done a trial, which we're just writing up now. Hopefully it will get published sometime soon this year. But we've actually provided aging volunteers with a nicotinic acid analogue. So it's called Esipomox. It's a drug that's already prescribed by GPs to treat hyperlipidemia. But we've looked at it in the context of aging, where we think the mitochondrial baseline phenotype might be lower than, say, when you're young and perhaps slightly healthier. And we gave that drug for 2 weeks to see what the impacts were on the mitochondria. We have a small study, it's a pilot study. So we had 8 in the nicotinic acid group, 10 in the placebo group. But what we do think we are seeing is possible increases in mitochondrial content measured through citrate synthase, possible increases in complex electron transport chain complexes, and possible increases in mitochondrial function when we looked at using the oxygraph as a measure. So we think that there's, in humans, in aging humans, healthy older humans, we think there are some interventions that might be efficacious, but I don't know whether that might impact being a responder or a non-responder.
And you got a number of questions about that, didn't you, in the panel discussion about all the healthy triathletes in the audience here that were trying to boost their function?
Yeah, the field in itself is very controversial because there's a lot of preclinical evidence that's extremely strong in the field of NAD. I mean, there's just so much literature I won't even go into, but it's really quite effective that if you give an NAD precursor, you can really boost mitochondria, you can improve muscle and so on. But actually, a lot of the human literature hasn't really translated into the human context. So a lot of people out there have used nicotinamide riboside, which is also an NAD precursor. But the difference is that if you use nicotinamide riboside, which hasn't been shown to be very useful in humans, it goes via a different biochemical pathway effectively to produce NAD, whereas nicotinic acid and what we've used through Esipomox actually goes via a different pathway to generate NAD, and we're seeing some improvements there. So we think that might be the difference between it. But yes, there's so much controversy in the literature.
But that's also quite exciting that you've got an established drug. A lot of the translational work or lab-based work can take sometimes maybe decades or a decade or more to actually reach the bedside. But with both of what we've talked about, we've got exercise and an established, already signed off drug. So that's quite exciting that there are 2 interventions that can be implemented pretty swiftly.
Yeah, absolutely. I think that's kind of the key from, using a siponmoxone nicotinic acid, that it is already prescribed by the GP. So it's effectively repurposing it. And I think that's where a lot of the field, and certainly my interest is actually seeing what drugs are already out there that might be able to have an impact on something that we might not know yet.
So, and exercise is free. Exercise is, it could be prescribed, and we use it as though it's a drug. So it's a tailor-made prescription, which is personalized to the individual. So playing around with doses, there is a wealth of literature now that we think that HIIT training gives you enough of a stimulus to drive improvement in outcome, be it a tumor outcome or a post-operative improvement in complications, for example. But so we need to be very mindful of how to tweak that drug. We wouldn't want to lessen the effect. We want to really ensure that this is a prescribed thing and that this is dose monitored and dose tailored.
So again, we touched on this in the panel discussion, but from the policymakers' point of view then, are we at a stage where exercise, whether that be HIIT or other forms, has got the evidence-based, the safety profile, if you like, the trial evidence that it should be prescribable? Should we be having national, international policies on preventative medicine using exercise and patients being prescribed?
And there are lots of physical activity, WHO guidance. There are also AACR exercise guidance for healthy individuals and also patients, including cancer.
Guidance, Malcolm, but just push on the point, is it prescribed?
So I was going to say, the guidelines we have here for healthy volunteer or healthy patients, or people, I should say, not patients, but 150 minutes a week.
Yes.
And it's not evidence-based.
No, so the prescription element is the most important. And I think we're at that critical stage now where we have efficacy and effectiveness for an exercise intervention which is prescribed and bespoke. I think looking at the big prehab trial that we've just been part of, and also all our other work in the past 15 years, I think we're at the critical stage where we think that we can influence policy, and that's what we're trying to do.
That it should actually just be part of your neoadjuvant treatment.
Correct. It's part and parcel, like you go and get a CT scan.
Yeah, exactly.
It is part of the treatment pathway.
Possibly a naive question, not being clinical, but if that was the case, do all hospitals have the infrastructure to make that happen?
Yeah, that's a really good point. No, is the honest answer.
Right.
We're quite blessed in Southampton that we have a big perioperative medicine program, a big prehab program. We are at the cutting edge of, we think we're at the cutting edge of what a prehab program and a perioperative medicine program should be like. Mm-hmm. But there are hospitals in the UK, even a few miles away from Southampton, that don't have the infrastructure. And that's where the policy comes in. We need to advocate for screening assessment of all major surgical patients, including cancer patients, and then intervention where appropriate. And that's where your screening assessment and prehab interventions will make a difference.
We've just heard, Joff, bringing the international experience back in from Australia, we just heard where we are in Southampton, but are other countries around the world following that, do you think?
Probably my experience in Melbourne was probably not reflective of the country as a whole. So I worked at the Peter Mac, and I know there's some people from the Peter Mac who are talking at this conference, which has a very well-established perioperative pathway, and there was a huge amount of support for patients, certainly who showed less than desirable results in the CPET, that they then have a tailored exercise program and a retest to try and bring them up to what we might deem, mitigate their risk profile. So that was an excellent program and well established, but as I say, I don't think necessarily reflective of the nation as a whole.
So there's pockets of excellence, we think, going on in certain places, but there's other places where we need to help encourage get that work out there.
Yeah.
So I think we should probably draw it to a close due to time reasons, but again, I'm going to come around each of you in a second and ask, I guess, where you think the next big steps are going to come in this journey, what you think the next exciting stages are. We talked about a few of them already, but what do you reckon is going to be the next big movers forwards?
I think from a surgical tumour point of view, I think the next big step forward would be the addition of exercise as an adjunct to currently recognised standard treatment pathways, so current cancer therapy, but also the addition of exercise to immunotherapy, which is a new kid on the block. So not only we influence quality of life and all of those all important patient important factors, but also the surgical outcomes and the long-term cancer outcomes. I think that's the next step.
Exciting.
I think for me, we've already touched on it, but it'll be having a way to identify responders versus non-responders, so we can get that true personalisation throughout their whole kind of surgical pathway to improve their outcomes.
I think as the jobbing anaesthetist, the product of that being that I see patients with maybe a more finely tuned risk stratification that I can then plan a more tailored perioperative pathway for them. So that would be great.
Brilliant. Well, thank you all very much for your time. Thank you all for joining us here on Top Med Talk. As always, you can find us on our app, on our website, on whatever your podcasting platform of choice is. And make sure you also follow us on Facebook, on Twitter, or X as it's now called, on LinkedIn, and give us a like and subscribe on YouTube as well. Thank you all for joining us. Thank you for joining the conversation.
Thank you.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.